moving on to Venus, so kind of similar kind of structure to how I've organized the second half of the our session here. So first off, kind of talking again about some protocol stuff. So this is a big one that I really wanted to get your guys' opinion on was imaging of calf veins. So I think that's really a big thing on the adult side, and I'll show on the next slide as well. The kind of formal recommendation is that a complete lower extremity Doppler examination should include the calf veins. We historically we used to just say, if there's a clinical indication or if they have vocal symptoms, then we'll look down there. But I would say definitely a minority of cases did we end up doing that. I kind of arbitrarily made this decision to have it be this 10-year-old cutoff. So we've started doing this probably about, I'd say like 6 or 8 months ago. So if they're over 10 years of age, then we include the calf veins by default. If they're lower than 10, then we kind of have this either calf pain or swelling below the knee, then we'll include them. But I don't know, it's totally arbitrary, like I said, but the kind of younger kids, oftentimes the calf veins are probably not super clinically important, and they're also very challenging, I think, to see. So that's kind of why I settled on this 10-year limit. But I'm curious what your guys' thoughts are. If you guys treat them like like the forearm stuff, if you only image the calf veins, if it's a clinical indication, or if you have something similar to us where it's a, default, some age cutoff, or kind of what your approach is to that.
I have mixed feelings. So, on the adult side, I remind me if the guidelines on the adult side actually changed or not. I know there was discussion of it used to be stop at popliteal and only if there are calf symptoms or foot symptoms, scan distally. But did that get updated actually or no?
Yeah,
I'm gonna
yeah. So this was
tell you my
this is
ignorance.
from this multidisciplinary. This was from the SRU. So they kind of these are the different historical protocols that have been described, which I'm not super familiar with these, but like they call this the two compression ultrasound. So like some people, I guess, only did compression at the CFE and at the knee. Um, but this one, what they call the complete Doppler ultrasound, is what the current recommendation is. So the dark black line is to do compression images. So every centimeter or 2 centimeters, you're supposed to do just compression images pretty much all the way down to the ankle. And then the color and spectral waveforms, you just do at the popliteal vein and common femoral vein. Um, so this CDUS is kind of the one that this, at least from this consensus, is what they recommended as their like complete protocol for adults, and they recommended this as like the standard one.
I love the SRU so much, but I don't know. I feel like we get asked. So usually in the adult population, they have a dedicated vascular lab, right? I feel like in our hospitals, we're asked to run a vascular lab plus everything else, you
Right.
know.
Yeah.
So I do agree it's probably indicated for like maybe the older like teenager who is on birth control or has
Right.
a higher pretest probability, but I really hesitate to make my to ask our sonographers to take that extra time with every single one of these DVT, especially when the pretest probability seems like it's pretty low.
Right.
Um, I haven't made up my mind. Can you tell? I'm like, I'm not sure what to do still.
Yeah.
Probably we should change it so that if it's, I, I don't know about 10. Is that too young? That's
Yeah.
probably a
I
good
feel like it
age,
probably is.
actually.
Yeah, I might need to revisit that. I mean, it would be interesting to go back and look. We've been, like I said, doing this for a good bit now, and I'm not sure I've seen any caffeine clots in any of my ones that I've read. Kelly, I don't know if you probably get exposure to more of them, but have you seen any of like that we just picked up in the calf that didn't have focal symptoms on there?
No, I not off the top of my head can I think of any that we have, but from the sonographer side, when we're learning about DVT and these lower extremity, in school they're telling us the calf, that's where these start. And I know that is focused mostly on the older patients, but when we're looking at patients that are concern for DVT due to long car ride, long plane ride, those kind of things. I do think it's really important to look in the calf because we might miss something. But, honestly, I don't know that we have seen really caught any thrombus down there. Most of the kids we're doing really are, follow up from lines, from clot, or, from access, pre-access studies, um, or just indications that I don't know, don't necessarily make sense for the sonographer. They're just kind of just wanting to rule things out. But yeah, I don't know that we've seen a whole lot of benefit from adding that in.
Jeffrey, this sounds like yet another research idea for you.
Yeah.
Like, obviously, this is not the catheter-associated thrombosis because that's a little bit of a different story. But like when you're just sort of screening otherwise healthy outpatient, whatever.
Right. Yeah. Yeah.
That tell us what you find and what we should be doing.
Yes, it will. Yeah. My general indication that this is probably too young. I think maybe like, I don't know, 14 or 15 might be more reasonable. So yeah, we'll revisit that. The other kind of protocol questions I had, they do specifically recommend on here. So looking at both the right and left, either common femoral or external iliac vein is like a specific recommendation on here. We did include that in so all unilateral exams, the common femoral vein is kind of where we picked to do that comparison image. I would say I'm not sure I've gotten a whole lot of value out of that. They say just because I don't know that I paid as much attention to a lot of the venous waveforms, and like I feel like a lot of them, it's really hard to know how symmetric they really are because there's so much variation in how they look. But we did add that probably about 6 months or so ago. And then the other thing we recently changed about our protocols, we always did these compression images, but we used to do a lot more kind of color and spectral images kind of coming back up. So typically the sonographers would do compression down and then get their color images in long, kind of pretty much coming all the way back up to the common femoral vein. I did just kind of shorten that for them, now we only just do color images at the popliteal and then at the confluence and then the common femoral vein next to the iliac vein. So we're a little bit more than the official, recommended protocol. But we did kind of shorten that up just to kind of make the protocol a little bit shorter for the sonographers. These SRU guidelines, they really focus a lot on compression kind of being the main thing that we look at, and the color and the spectral are kind of just, secondary pieces of information. I think with kids, just because their vessels are so small, the compression I think is hard to tell sometimes, which is why we ended up choosing to do a little bit more in the realm of color than they recommend. But that's kind of what we settled on with that. And then as far as the upper extremity, so this is kind of same thing. So we mostly followed the recommendations. This was kind of interesting. So they recommend, doing compression everywhere, but then the color and spectral, they just say, the brachiocephalic, brachiocephalic, basilic, and they say may be recorded with color Doppler imaging. We didn't end up including some of these again, just because those vessels can be kind of small and they can be better depicted with color sometimes than necessarily with compression. And then again, so that for the upper extremity, they recommend including the right and left subclavian. But again, I'm not sure I've gotten a whole lot of value out of that. Are you guys doing this bilateral comparison imaging on all of your venous studies, or what's your kind of thoughts on that?
I think we're doing comparison for the lower extremity. I'm trying to think. I don't think we do it for upper.
We do. I rarely find it adds value.
Yeah.
Anecdotally.
Where do you do it for the upper?
We do upper and lower.
Oh, yeah. But where? Like all?
I can't remember if the protocol says IJ or subclavian, and I think sometimes the sonographers will just pick one or the other. I'm not sure I care too much. I will say, I think the only time I can remember it being useful was when it's like a kid with history of multiple prior catheters. They ask us to look at one side and then the other side happens to be out also. So the comparison has been like, oh, well, that side's out too. Don't go there either when you attempt to put your next line in. But I can't say it's been helpful for like any of the like lower pretest probability cases.
Right. Yeah.
Yeah, because I think for access, we automatically do bilateral, but mainly central, like wherever their axis is. So that kind of takes care of any questions of like, oh no, we went into the wrong side or whatever, and don't have access. But yeah, just kind of evaluating for DVTs. I'm not sure if I saw anything useful for venous.
What's interesting is we made a shorter vascular access like protocol. So just looking at the main vessels, but sometimes they still will only order one side for these like higher pretest probability kids for whatever reason. So I'm not sure why they only order one sometimes when we have like this whole shortened protocol so that they're not like going into the calf on a kid where that's not their question at all.
Right. Yeah, we have a similar one. And then the other protocol question I had is we kind of have a hard line from brachiocephalic to SVC. Like if they ask for, if they are worried about SVC occlusion, we kind of just say, sometimes I feel like we can see the SVC depending on the body habitus, but we kind of have made that be more of like an echo type question. Like if they're worried about SVC something, do you guys defer that, or are you guys willing to look at that?
We refer to echo usually. Well, brachiocephalic is usually our cutoff, but
Yeah.
depending.
Yeah.
But yeah.
Yeah, same. I don't think we routinely look at SVC enough to even do it confidently.
Right. Yeah. And then again, just showing our notes here. So this is kind of a similar to what I already showed you. Again, thank you to Judy for these nice diagrams here, but these are kind of what our text will draw in here for us. Then another big topic, I know we've kind of already chatted a bit about this, but I want to just kind of bring this up in a more this environment as well. So the idea of this kind of four extremity duplex ultrasound, I think a lot of us, sounds like Judy maybe doesn't struggle with this as much anymore, but we have a really, I think, problem with this. And I'm not sure where it comes from historically, if this was like older literature, what exactly all of our clinical colleagues and why they like to order these so much. But we get these for all kinds of different indications. I'd say the biggest one, like in this case series here, is the fever of unknown origin. They're looking for, bacteremia or something like that. We get a ton of these, and it's really a time sink for our sonographers, and they're expensive. I think it's really just not the best utilization of resources. So they kind of concluded that in this paper as well. This is not pediatric specific, so maybe we need to look at that in our patients as well. But I'm curious, what your guys' experience are with this, with these kind of four extremity exams, and kind of what potential solutions we could have to kind of address some of these things.
What we did is we went to I think it was only a couple of people in the PICU who were doing this, and I think it was based on like some sort of older literature, or anecdotally they saw like an infected thrombus as the cause of fever of unknown origin. But I completely agree. Our sonographers, especially with their overuse injuries, like these take a long time to do.
Right.
And so I was just basically like, show me the data, show me the literature. And then they stopped ordering them. So that's what I would recommend. Don't fight the battle, like each individual battle, fight the overall war, if you will. What a terrible like analogy, but go above to leadership to be like, all right, let's have a protocol in place that makes sense for these things.
Yeah. Yeah, I think it's been interesting. Like, I mean, we kind of see this. I think that's been one of my challenges. We just see this from a lot of different places. Like, there's so many different people that are ordering extremity ultrasound. So like, I recently reached out to hematology just to kind of see what their general thoughts were. And then I'm trying to assemble like a team of people from different subspecialties, like, infectious disease and hematology, PICU, cardiology, all these different places. But what I think it's just when we're in a big system, it's just so hard to get everybody on the same page. Like, and I'm high tweet from, work with volvulus ultrasound, like getting all these different players on board and getting buy-in from so many different people is such a big challenge for, these kinds of things. So work to do for sure, but.
I know. Yeah. If you can figure it out, Jeffrey, let me know. But maybe, I don't know. Yeah, we can try to go. So did you just go directly to not the individuals, but like the PICU
NID.
director? And
yeah. You could also like do a retrospective review of all your cases. Again, I'm giving you more work to do. Sorry. But like if you can show, this is not work. This is the pretest probability and post-test probability is not high enough in these patients to warrant. You also, sometimes the clinicians, they just don't realize it takes like an hour to do, sometimes longer, depending on if it's a patient with complex medical history and they have like contractions or whatever the case may be. And these are always portable studies up in the PICU or wherever. And it is not great for the sonographers to kind of be contorting their bodies to be able to scan these patients. So this is one of those things I felt really strongly that we, when it's indicated, yes, we're happy to help look at one extremity or whatever, but we're not going to do a whole body DVT. That's crazy sometimes.
Yeah. Kelly, would you mind just talking to, like, from your perspective, just, I know we've talked a lot about this, but just kind of the impact from the sonographer point of view, that, how challenging these are to accommodate, I think, from your workflow perspective.
Yeah, of course. So I agree completely. It takes a lot of time, especially a lot of like often these are ordered on really critical patients with and very vague indications. And when our sonographers try to reach out to the providers to get, some clarity, um, get these down to the symptomatic extremities, we're often met with, we put the order in, just do it. So we, loop in our radiologist at that point to try to educate or, try to get them down. Um, but yeah, it's a very long exam on critical patients. And quite frankly, I don't know that we've ever actually found something on these four extremity Dopplers. You might have more on that, Dr. Tupman, but I think from when we talked about this last, it's it's been pretty much just a screening exam. And I do think that the ordering providers just truly don't understand the complexity of it for the sonographers and how long it takes when we've reached out to them and said, this is an hour plus exam. Can the patient handle that, amount of uh, just interacting with them, that amount of stimulation. Oftentimes we're told, oh no, you can't. We have to break it up into, uppers and lowers, which is even more of a burden on the sonographer and, having to come and go. So these are really a big challenge at our facility right now.
Yeah. Yeah, definitely work to be done on this. So I'll let you know
And
how it goes.
I also wonder if some of this is coming from, we have uh not to like knock my adult vascular surgeon colleagues, but a lot of the things, the requests that we get that just don't quite make a lot of sense are because a vascular surgeon who's on the adult side has recommended it. And
Sure.
they have to remember that it's not a vascular lab that we're running, it's imaging Doppler.
Yeah.
So I would also recommend if that's where some of these orders are coming from, reach out to the adult vascular side also.
Yeah, that's a good point.
Yeah, maybe we can do a multi-institutional study, kind of collecting thousands and
We
thousands.
certainly have a lot.
No, thank you.
I know, so many ideas, but so little time.
Yeah. And then from the same paper about the kind of recommendations for describing venous waveforms, so they talk about direction, flow pattern, and spontaneity. So the directional flow, I think this is, again, it depends on what vessel you're looking at. So we need to keep in mind it's normal for the vein being evaluated. So again, antegrade, retrograde, and absent, I think are all pretty intuitive. The flow pattern, I would say I'd honestly probably maybe should pay a little bit more attention to this. I think honestly, I don't it's really, I think, hard to evaluate this in a lot of our patients. So I don't necessarily put a whole lot of stock in like making diagnoses from some of these different flow patterns. Are you guys similar?
The one thing that especially the lower extremities, I super pay attention to is respiratory phasicity. So
Yeah.
especially like a bigger patient where you can't see the IVC,
Yeah.
I make sure that there is respiratory phasicity if it's a vessel that there should be. Like I steer away from like, oh, this is the cardiac shunt of this and that.
Yeah.
I'll say something like maybe central in nature if it's
Yeah.
like a funky antegrade and retrograde flow or something like that.
Yeah. And then spontaneity is the other one. This was kind of another protocol question I had for you guys. So we used to do augmentation for our lower extremity venous studies. The practice parameters say it's kind of optional, and I think we weren't necessarily finding a lot of value in it. Do you guys routinely do augmentation or occasionally? I think we pretty much never do it anymore.
I think we still do it. And I think maybe an argument against having to sample the distal calf veins. I mean, it's kind of like sampling those. Like if you can squeeze the calf and there's, transmission, then in theory, there's no thrombus in the calf veins. I
Yeah.
mean, that's how I understood it. So yeah, we do that, but we do not go down to the calf veins.
Yeah, we're the same.
Yeah, and then kind of one of the arguments against it was the sonographers that told me that doing those augmentation maneuvers, like we were talking about with MSK injuries, is pretty hard on them. So we have taken it away. I'm not sure we've lost much from it, but yeah. So And then again, kind of normal venous waveforms. So this is kind of the classic venous pattern, but I would say, and especially talking about the extremities, we don't see these kind of discrete things very often. But these are kind of their examples of kind of normal venous waveforms. Then a couple of cases and then specific questions related to those. So one of the questions that was also submitted was about kind of standard follow-up recommendations. So this is just a typical case of an occlusive acute thrombus. So this is from that paper I referenced earlier, the SRU consensus guidelines. So they kind of talk about this issue of there's really not standardized follow-up recommendations. The two recommendations they make are that if the patient is on anticoagulation, then there's really not a reason to do imaging during that period of anticoagulation unless it's going to change their management. I'd say anecdotally, we not infrequently will image them like in the middle of their period of anticoagulation, and we're not really sure like what they're looking for. There's not really a clinical reason for it. Do you guys make specific recommendations in your report? The other thing they say is like they do recommend a repeat at the end of anticoagulation just to make sure if they're scarring or get a new baseline, which I would say again anecdotally we probably don't see that many come in. Like they just treat it, and if they're clinically improving, they might not re-image them. So if you see something like this, are you making any specific recommendations in your report about follow-up, or do you kind of just let them decide clinically?
I don't recommend it. I think our hematologists have like an algorithm that they follow. So if it comes from hematology, I do see a follow-up. Same thing when it's a cardiac patient who initially was catheter-associated thrombosis. They routinely follow those like at the end of anticoagulation therapy.
And then one of the other questions related to this was, I know Kelly and I have talked about this, is that if they request, like if they had a case like this with a bacillic thrombus and they request a follow-up ultrasound for whatever reason, do you guys do targeted exams just to the known area of thrombus just to see if it's improving or extending or kind of what the status of the known clot is, or do you do a full repeat of the entire protocol?
I guess depending on timing, if it's been a while and they truly want to assess like how things look, like we do tend to repeat the whole thing. But if it's like super short and I have no idea why they're repeating it in like one day or whatever, then I try to, if I'm on, like I just say, keep it, kind of focused,
Yeah.
but evaluate the area and then extend a little bit above and below.
Yeah, for us, it depends. Sometimes if it's a superficial vein and they're not anticoagulating and they're like looking for a reason to start anticoagulating, then we'll do like a tailored exam, like has the clot propagated, is anticoagulation indicated at that time. But usually we repeat the whole thing because it has been long enough to, we've done a pretty good job, except for the immediate post-cath patients where they have an algorithm where they want to look at it more closely. We've done a pretty good job of not imaging them too frequently, when it's not going to actually change their management.
Yeah. We ended up deciding to, if the original clot was in the superficial venous system, then we were okay with doing a targeted exam and just making sure they're showing the full extent of it, the proximal and distal end of it. But if it was in the deep system, even if it's, then we've said to do the full complete exam if they're requesting a follow-up. So again, I think that's kind of arbitrary, but that's just kind of what we settled on. Then this was kind of just an interesting case. So this patient had a CT. So you can see there's, contrast. It's kind of, this mixing artifact, I think, in the IVC. And then as we get down into the legs, this ended up getting read as an iliac thrombus. It's, certainly asymmetric from the other side. This ended up being, after we did some more investigation, this patient had like 5 follow-up ultrasounds for this, follow-up of clot, and we never saw anything at all. These looked totally normal. So we ended up looking into this, and this patient had a lower extremity catheter where they got their IV injection, and we historically didn't really have a great process for like us being aware of what catheter got injected with contrast. So it was really difficult to find that information in Epic. So we did end up changing that, but this was kind of just an interesting case. When you see stuff on CT, just remember that ultrasound is believable. You don't need to do it a bunch of times. And a couple of cases, just again, I mentioned before the artifact you can get from oscillators. So you get these very weird looking waveforms. In these particular cases, I rely a lot more on the color imaging and the compressibility just to making sure they're patent. But you really, I think, completely lose that ability to assess the waveforms. Then this, I think, was even a more challenging one. I've just had this one recently. So this patient, again, had bandage over the area that they were actually worried about. And then this almost looks, artifactual to me. Like you can see there's pretty much symmetric above and below the baseline. So again, it's really hard, I think, to, make much of a determination in a case like this. But, we can at least see color in there. We could compress it. So I kind of say it's limited, but, just recognizing that, oscillators can certainly cause these very weird looking waveforms. Then again, another kind of terminology question for you guys. So this patient, I didn't show the priors, but this patient had this eccentric material that had been in there for several different exams. So this is again from that SRU paper. So they, as far as how they talk about the terminology, they recommend this word of chronic post-thrombotic change. They make the distinction that after you have an acute DVT, it kind of turns into not thrombus anymore. So we can say, if we say chronic thrombus, clinicians can interpret that to mean that there's still something in there they need to treat. Or same thing if we say residual thrombus. So this terminology of chronic post-thrombotic change is what they have recommended. I'm probably personally not very good about using that word. I'm curious if you guys have different thoughts on this as far as like what terminology you would use for something like this.
I do use it because I paid attention during that one SRU talk that one year. Remind me, and I'm so sorry to like be dumb about this. What do you call it when there's like no residual vessel lumen left? Like, so there's no vessel because it's chronically thrombosed and you have collateral vessels. Is that also chronic post-thrombotic change or no? You know what I mean? When when that vessel is gone, it is completely replaced by collaterals.
Yeah, that's a good question. I don't know if it just as that kind of scarring is occurring, if the vessel wall is just getting adherent to itself and just obliterating it. I usually just use the word obliterated or not visible or something like that with collateral
Yeah.
formation. I personally have not called that as, chronic post-thrombotic change, or I haven't put it in that category personally, but I certainly might be.
Same. I don't think I've put in that category either, but I do describe it as, just kind of like fibrotic change as a sequelae to probably like prior known thrombus.
And then a similar case, so this patient, this was known to be.
Oh, Jeffrey, kind of similar to that line. Like, do you guys ever call like fibrin sheath? And then, how would you know the difference?
I do when it's like a linear thing related to like real clearly related to the catheter.
Yeah. Yeah, same. I think history is really important for those, like knowing they had a line in that location. And then if you see that kind of tubular looking thing, that's when I kind of use that word of, fibrin sheath. And then this one, so this was, again, just kind of curious what your thoughts are on like how you describe stuff like this. Like this was known to be relatively more acute just based on when they were decannulated. But you kind of have this eccentric, kind of non-occlusive thrombus in there. I personally, like when I see something like this, I don't know, I don't personally use the word of like acute. I would just be more descriptive as far as like eccentric or non-occlusive, kind of the big words I use. Do you guys have other kind of terminology that you would use for something like this?
Same. Your description is like exactly what I would say.
All right, good. This is my last case. So this was kind of just an interesting one. So again, just kind of showing our discussion of fibrin sheath. So this was a patient that had an IJ line. It got removed, and then they started having this purulent drainage from the skin site where the catheter previously was. So I know this image is a little bit hard to see, but this is the vessel right here, and you can see there's this kind of echogenic stuff within it. Then on the compression view, at least part of it compresses down, but there's still some material within the lumen itself. Then play through this cine here. So you can kind of see there is this kind of tubular looking thing right here. Then I'll play through one more time. So you can see that in the vessel lumen, there's kind of this more echogenic looking component to it. And then the next cine as well. This is the vessel right here. So you can see all that echogenic stuff within there. So this one, based on this look, so there's this kind of tubular looking thing that's in the subcutaneous tissues outside the vasculature. We ended up concluding that this was probably a fibrin sheath that got like partially pulled out of the vessel as the catheter was being removed. And so it's kind of leading down into the track where the catheter was, and then there's kind of the echogenic piece of it within the lumen itself. The patient never, they were just treated with antibiotics, so we don't have definitive confirmation that that's what this was, but that was kind of our best guess, just kind of based on this kind of tubular look to it. And I've never seen that before, so that was kind of interesting.